morning, everyone. Welcome to Cardiology Grand Rounds for November 14th, I guess. Morning, it's my great pleasure to be able to introduce Sara Partington. Dr. Sara Partington was with us as a fellow. We were fellows for several years, back about 15 years ago, I guess now. Dr. Partington began her career in Hamilton, where she did med school and internal medicine. She then came here for her cardiology fellowship. After that, she moved on to Brigham and Women's in Boston, where she did a fellowship in advanced cardiac imaging and heart, as well as a master's of public health. After that, she completed her training there, although we tried to convince her to come back here, I believe. Ended up going to Philadelphia, where she currently works at University of Pennsylvania there and Children's Hospital. Her area of expertise is in advanced cardiac imaging and congenital heart disease. She's a cardiac MRI here, as well as an echocardiographer. And we look forward to her talk today, which is on coronary artery abnormalities and ischemia evaluation in congenital. Welcome so much, Sara. Look forward to your talk.
Thank you so much for the very kind introduction. And the forward, sorry, I should have asked this before. For advancing the slides. Is it the? Oh. Okay, perfect. Yep, got it. Okay, perfect. Sorry. It's a real pleasure being here today and seeing so many people who were so instrumental in my path through cardiology. It's also a really great pleasure today to talk about coronary artery abnormalities and ischemia evaluation and congenital heart disease. This is a topic that's really near and dear to my heart. It combines my two big clinical interests, congenital heart disease and cardiac imaging. And I think it really gets to the crux of adult congenital heart disease, that intersection between the congenital heart disease and acquired heart disease. So with that, I have no disclosures. And so what I hope to do over the next 50 minutes or so is recognize the causes of myocardial ischemia in patients with congenital heart disease, contrast the advantages and disadvantages of our various non-invasive imaging modalities for diagnosing ischemia in this population, and finally construct a diagnostic approach for assessing myocardial ischemia and congenital heart disease. So I'm going to start with a case, and this is a case of another chest pain referral, but it's not the typical referral you might be seeing for chest pain. This is an 18-year-old who was born with transposition of the great arteries. For those of us that don't see transposition of the great arteries every day, it's a type of congenital heart disease where the atria are in normal position, the ventricles are in normal position, but the aorta is associated with the right ventricle, pumping deoxygenated blood to the systemic circulation, and the pulmonary artery is associated with the left ventricle, pumping oxygenated blood back to the lungs. So as you might imagine, this physiology is not generally compatible with life. And this boy was also born with two associated abnormalities, very common in transposition of the great arteries, of VSD and pulmonary stenosis. So there are a few different surgeries that surgeons can do to repair this type of congenital heart disease. In this boy, the surgeons took advantage of this patient's ventricular septal defect and performed a Rastelli procedure. The Rastelli involves baffling the left ventricle to the aorta via the VSD. And because the pulmonary valve is stenotic and not functional, a right ventricle to pulmonary artery conduit is placed. So this repair corrects the cyanosis. The left ventricle is the systemic ventricle, or the ventricle associated with the aorta, which is also ideal. But the big disadvantage with this surgery is that this right ventricle, the pulmonary artery conduit, does tend to degenerate, leading to pulmonary stenosis and regurgitation, and is not uncommon in patients with this type of repair. This boy required 3 additional surgeries to replace that right ventricle, the pulmonary artery conduit, before he was 18 years of age. So when he developed more conduit stenosis and regurgitation, his cardiologist appropriately hoped to avoid another open heart surgery and referred this patient for a catheter pulmonary valve replacement, which was available at that time. And the procedure went well, but shortly after he developed retrosternal chest pain with exertion, very concerning for angina. This is his ECG. You can see he has sinus rhythm with a marked sinus arrhythmia, right bundle branch block with repolarization changes. And the question for us was, is this ischemia and what should we do? So I'll let everyone think about what they might do in this scenario. And we'll come back to the case later in the presentation. But what I want to pose to you is, how much should we worry about ischemia and adult congenital heart disease? Like, the first thing we really need to consider is that our patients with congenital heart disease are living to older ages. And as we live to older ages, they're at risk for atherosclerosis, just like the rest of us. For anyone who spends any time in the operating room, you might recognize what this is. It's the cardiopulmonary bypass machine. This is the instrument that cardiac surgeons use during cardiac surgery to divert blood away from the heart, oxygenate it, and pump it distal to the heart so that the surgeon can allow the heart to be in standstill, work in a blood-free environment while still perfusing the other organs. So you can imagine, before the advent of the cardiopulmonary bypass machine, all cardiac surgeries that could be done had to be done on a beating heart, really limiting what a surgeon could really do. And so there were just a handful of procedures that surgeons could do that were mostly palliative at that time. And for anyone who has any interest in medical history, the first time a cardiopulmonary bypass machine was successfully used in a human was 1953. So really not that long ago, really. And it wasn't for another 20 or 25 years that you could put a baby on cardiopulmonary bypass to do a repair. So if you think about it, patients with the most complex forms of congenital heart disease that required the most complex repairs were really only getting repaired in the last 25, 30 years. And these are people that are just starting to come into adulthood. So as you can imagine, there's more and more adults living with congenital heart disease. And this is what the data really shows us. This is data from Montreal, Quebec. I'm looking at the prevalence of congenital heart disease. The gray bar on the top represents babies born with complex congenital heart disease. And you can see that number has been relatively stable over the years. But what's really noticeable about this figure is the black bar below, which represents the number of adults living with congenital heart disease. And that number has been increasing year after year and continues to increase as there are improvements in care for children with congenital heart disease. There are now more adults than kids with congenital heart disease, so it's no longer should be considered, I think, a pediatric disease. This is a condition that we're all going to be seeing more and more of. And there are now over 1.4 million adults in the United States with congenital heart disease. And as there's more adults with congenital heart disease, we're certainly seeing more adults over the age of 40 with congenital heart disease. And of course, this is the group of patients where we're going to be most worried about seeing atherosclerosis. So beyond the fact that these patients are living to older ages and can be developing atherosclerosis, actually congenital heart disease patients may actually be at increased risk of vascular risk factors in the general population. So this is data from patients with repaired coarctation of the aorta. So a coarctation is a narrowing of the aorta, generally just after the left subclavian artery. And even after repair, the risk of high blood pressure is much, much more common in patients with repaired coarctation than the general population. And with that, there's an associated risk of increased peripheral vascular disease. But beyond the risk in patients with coarctation, we actually see more metabolic syndrome in all patients with congenital heart disease. And this is data from Seattle just showing that there is more metabolic syndrome in adults with congenital heart disease than age-matched controls. And I suspect the reason for this is probably very multifactorial and may have a lot to do with attitudes towards exercise and health behaviors in our congenital heart disease population. And so as we could expect, we do see rates of coronary heart disease similar to the general population in our adults with congenital heart disease. But beyond the atherosclerosis, there may be structural reasons why our patients may be developing coronary issues. And one of the main issues that we worry about in our adult congenital heart disease population are those that have required coronary reimplantation as part of their repair. This is most common in patients who have transposition of the great arteries, so similar to the case I presented earlier today, but rather than having a Rastelli repair, patients who have an arterial switch repair, where the cyanosis is corrected by literally switching the position of the aorta and the pulmonary artery. Now, in order to do this surgery safely, the surgeon needs to disconnect the coronary arteries from the aortic root and then reimplant them after the aorta is translocated. If the surgeons try to just move the aorta without removing the coronary buttons first, those coronaries, you can imagine, can get tethered, and it was leading to diffuse ischemia and death in these babies. But with the insertion of these coronary buttons, we do see increased risk of kinking of the coronary arteries and narrowing at the coronary artery anastomosis site. And this is well seen in a series of patients following an arterial switch. Now, this is kind of the early experience following the arterial switch surgery out of France. It's a case series of almost 1,200 patients following the arterial switch procedure who were followed for a mean of 6 years follow-up. And you can see about 7.5% of these patients had a coronary event during their follow-up. Now, some of these coronary events were actually a cath with significant narrowing of the coronary artery. So they weren't all clinical events, but a significant portion did develop coronary artery issues. And because, and you can see that the majority of these events occur right after the heart surgery, but some of these events can occur later on, into the later teens. And we certainly clinically in our practice seen some adults who are diagnosed with significant coronary artery narrowing in adulthood. So because of this known risk of coronary issues in these patients following the arterial switch procedure, the 2018 Adult Congenital Heart Disease guidelines do recommend imaging of the coronary for coronary artery patency, either a cath, CT, or MRI, in asymptomatic patients following the arterial switch, and in patients with symptoms of ischemia. They suggest that stress myocardial perfusion imaging may be reasonable. Now, there are other types of surgeries where coronary reimplantation is done. Patients with aortic valve disease who might have undergone the Ross, with connective tissue disease requiring replacement, but probably the majority of patients we see are following the arterial switch. The other structural issue that we can see in our patients with congenital heart disease is coronary artery compression. Now, this CT in the middle here is actually not a patient with congenital heart disease. It's a patient with pulmonary arterial hypertension who has a very dilated pulmonary artery that's under systemic pressure. But you can see this pulmonary artery is compressing the left main coronary artery, and this patient did develop significant ischemia from the compression of the pulmonary artery. So you can imagine that any instrumentation in the main pulmonary artery, say a stent or a catheter pulmonary valve, could certainly compress the coronary arteries. And of course, there are anatomic reasons why patients may have coronary artery compression. This picture here in the top left is a patient that was born with an anomalous aortic origin of the right coronary artery. And you can see when that happens and the coronary artery goes anterior, it can frequently have an intra-arterial course, so coursing between the aorta and the main pulmonary artery. And then sometimes it can in fact have an intramural course, so not only being intra-arterial, but also coursing within the wall of the aorta. And so the incidence of these anomalous coronary arteries is about 0.1 to 0.7% of the general population. The anomalous aortic origin of the right coronary artery, like we're seeing in this image here, is about 3 to 6 times higher than the anomalous left, but the risk of sudden cardiac death with this lesion is much more common with anomalous left coronary arteries. It's much more common immediately after exercise, and tends to be competitive exercise. So this is a bit of a talk on itself, but I will say that we do follow quite a few patients with anomalous coronary arteries. For those with anomalous right coronary arteries, the risk of sudden death with this lesion, particularly in patients over 40, is very, very low. So the majority of these patients we follow without recommending intervention, but some of these patients can die suddenly from this lesion, and it's a congenital reason why a patient might have a compressive mechanism for ischemia. And then finally, I'm going to talk a little bit about right ventricular supply-demand ischemia. And there's a few situations where we can see this. Probably the most common, at least now in our clinics that we're seeing, are patients who are born with transposition of the great arteries. So again, another patient with transposition of the great artery, rather than having a Rastelli repair or an arterial switch repair, these patients who are older, so are usually generally 40 years or older, might have had an atrial switch repair, where the deoxygenated blood from the SVC and IVC is baffled over the left ventricle, and then pumped out to the pulmonary artery. And then the oxygenated pulmonary venous return is directed behind this SVC IVC baffle to the right ventricle, and it pumped out the aorta. So this corrects the cyanosis, but it leaves the right ventricle as the systemic ventricle, or the ventricle that pumps to the aorta. And so you can imagine that this right ventricle becomes very hypertrophied, and these patients are at very high risk for heart failure, particularly as an adult. And this is a series looking at nuclear myocardial perfusion imaging in patients who've had a mustard repair. And you can see that almost all of these, actually all of these patients had abnormal perfusion imaging. There are some other structural issues that we do see in congenital heart disease, coronary fistulas, which can be more common with certain types of congenital heart disease. That's sort of a general list of things I think we need to think about when we're thinking about risk for ischemia in our patients with congenital heart disease. So if we're going to be seeing more patients with congenital heart disease with ischemia, do we have a strategy? How should we be thinking of diagnosing these patients? Well, I don't think I have to tell anyone here in this audience that when we think about evaluation for ischemic symptoms, we have a whole menu of options that we can think about. Everything from the exercise treadmill test, the stress imaging with perfusion imaging, looking at wall motion, anatomic assessments that are non-invasive, and then of course we always have invasive angiograms. I couldn't resist to put this picture in. This was our Stress Labs entry for the pumpkin contest this year. I thought it was fabulous. I have to draw everyone's attention to the name of this pumpkin, Anita Stentonowski. I don't know if they won, but I hope they did. I thought it was just wonderful. And of course, so when we think about what our options are for assessing for ischemia, we have the exercise treadmill test. Of course, this is a first line test. One of the challenges I think we really have in our congenital heart disease patients is that in a series of patients who had underwent nuclear myocardial perfusion imaging, the stress ECG component of that stress test was non-diagnostic or ischemic in 96% of the population. And I think that the non-high diagnostic rate is really due to the fact that a lot of patients with congenital heart disease have bundle branch blocks, repolarization changes from their prior surgeries. And so in general, the stress ECG, if you're doing it to rule out ischemia, you're generally going to usually need some sort of imaging to help clarify the diagnosis of the presence of ischemia or not. Then we have our stress imaging options. And so when we think of stress imaging, our first question is, what type of stress should we be using? And of course, we always prefer exercise for the same reason we all do. You get a myriad of extra information about exercise tolerance, heart rate, blood pressure response, oxygen saturation with exercise that you can't get with a pharmacologic stress test. But the other things that I think we really need to consider in patients who you're concerned about a compressive mechanism for ischemia, a vasodilator stress may not provoke ischemia in the same way. You may need that increased cardiac output of exercise or an exercise or a pharmacologic agent that more resembles exercise to really bring out ischemia in those patients. So when we think about perfusion imaging modalities for ischemia, we have stress MRI, which I know probably do a lot of here. A lot of our patients our congenital heart disease patients are followed by MRI anyway. So patients with tetralogy of Fallot who had a pulmonary, who have a severe pulmonary regurgitation, they are getting serial MRIs every few years to assess their RV size and function. It's tempting to think if they're going to do regular MRI, and we're worried about ischemia, should we add on, a stress component to that study? Some of the limitations I think of stress MRI in our congenital heart disease populations is that generally we need to use a pharmacologic stress. And then of course, a lot of patients have had surgeries, they have metal implants, and that can create artifacts in some patients. So this is actually a case of a 59-year-old woman with a history of a subaortic membrane and bicuspid valve who underwent a membrane resection and mechanical aortic valve replacement 25 years ago. She is an ex-smoker and had dyslipidemia, so she does have vascular risk factors. And she presented with ventricular tachycardia during a routine treadmill test. And so it was decided to do a stress MRI for her, both to rule out ischemia as a cause of her ventricular tachycardia, and also to assess for myocardial fibrosis as a source of the VT. So thinking about those ancillary information that we can get from our testing. This is her LVOT view by MRI. You can see that there's a void artifact here where the mechanical aortic valve is, but fortunately it did not affect the left ventricular myocardium, which we were very interested in looking at during this study. So this is her stress MRI. For those of you don't see them very often, we're going to see the contrast fill the right ventricular cavity, the left ventricular cavity, and then as the contrast goes out to the aorta and coronary arteries, we're eventually going to see blushing of the myocardium. This is our rest image here. So you can see the right ventricle fill, the left ventricle fill, and then nice even perfusion of the LV myocardium. Now, following a vasodilator stress here, you can see the right ventricular fill, the left ventricular fill, and then this big rim of endocardial lack of enhancement, really concerning for diffuse ischemia in this patient. This patient, she did not have any myocardial scar on MRI, didn't show those images, and she underwent a cath and in fact did have left main disease and underwent a CABG. So this is our experience actually doing stress MRI at their children's hospital. So probably a very different population that you're going to be seeing down in the Stevenson Center. But we actually can do, adenosine actually just recently, we're now doing regadenoson stress in our pediatric patients, just starting to. And we also have an exercise stress protocol we can do at our scanner as well. For the adenosine stress patients, the median age here was about 13 years. The majority of patients were having the stress testing because of coronary anomalies, so generally anomalous origins of coronary arteries. Some had Kawasaki's disease and others congenital heart disease. And then vasodilator stress was safe in these patients. Exercise stress at our scanner at the pediatric hospital, we do have a ergometer that we can attach to the bottom of the scanner. Patients can cycle, try to get up to a good heart rate, and then we push them right into the scanner and do our perfusion imaging. I think the exercise stress can be really helpful for a lot of what we look at in cardiac MRI, but in this group of kids that had exercise MRIs, none of them reached 85% target heart rate. So I think it's hard to definitively rule out ischemia trying to do an exercise protocol in patients with MRI. So we're probably mostly really we're going to be relying on pharmacologic stress. And then of course we have nuclear myocardial perfusion imaging. This is a really sensitive tool to detect coronary obstruction. Some of the challenges that we do see though in congenital heart disease is that we don't have great spatial resolution, so it can be it's hard to know if when you see a perfusion defect that's fixed, whether it's prosthetic material or infarct. So you have to really take into account the patient's repairs and anatomy when you're interpreting these studies, and there is a radiation burden. We're going to look at a nuclear perfusion scan at the end when we go back to our case. So for now, we're going to talk about using wall motion to assess ischemia in these patients. And of course, probably the most common way we do that is with a stress echo. Really nice option because there's no radiation exposure and echo is quite available. But one of the challenges I think we see in patients with our complex congenital heart disease is that the imaging planes can be really unusual and can be difficult to interpret. So this is a patient with hypoplastic left heart. The left ventricle is very small. The right ventricle is the pumping chamber. And they had a Fontan repair. Oh, sorry, this is not cycling. But you can see how unusual the right ventricle is. It's very trabeculated, really hard to determine if there's any wall motion abnormalities. And then with exercise, you can imagine how difficult it would be to definitively rule in or rule out a new wall motion abnormality in these really atypical ventricles. But I think for patients that have a less complex congenital heart disease, so two ventricles with the left ventricle being a systemic ventricle, I think stress echo can be a really nice modality. And then of course we have excuse me. We have anatomic ways we can assess the coronary arteries, not less invasively. The cardiac CT. Now, this is a patient who had transposition of the great arteries with an arterial switch procedure. So these coronary arteries were reimplanted. You can see this left coronary artery is right here in between the pulmonary artery, and that looks like it has a very small ostium. And this patient went on to have this coronary artery reimplanted and patchplastied of the left origin. And then, of course, we have our invasive cath testing. So what should be our approach to assessing ischemia and congenital heart disease? Well, this is a schema that was published for general adults with concern for ischemia. And I think there's a lot we can take from this when we're applying it to patients with congenital heart disease. Now, the first question is, can the patient exercise? If yes, we should probably use a modality where the patient can exercise. Has there been previous coronary revascularization? So we're really asking, is this patient going to be at higher risk for suspecting ischemia? And I'd encourage people to think about coronary reimplantation or structural reasons why the coronaries might be abnormal as an equivalent to prior revascularization. And then, is the resting ECG interpretable? And in the majority of patients, the repolarization changes or bundle branch blocks make the ECG less interpretable. So the majority of patients that can exercise, we're probably going to recommend exercise, nuclear myocardial perfusion imaging, or exercise echo. For those that can't exercise, you certainly have more options available to you. You can do, pharmacologic stress echo, nuclear MPI, but also MRI, and then of course CT. And this is a sort of a more specific approach really for congenital heart disease, thinking about what you suspect the potential mechanism of ischemia might be, and using that, and then using that to determine what sort of testing you might want to do. So if you're thinking about a dynamic obstruction, so a compressive mechanism to ischemia, you certainly want to think about doing exercise. If the patient can exercise, then and you need to use a pharmacologic agent, I'd really encourage using dobutamine, which is a more physiologic representation of exercise, increases the cardiac output, and may be more likely to bring on a compressive mechanism to ischemia if that's present. For fixed obstruction like coronary artery disease, of course, exercise, but vasodilator stress may be a very reasonable option as well. And then microvascular dysfunction is its own topic on itself. So we're going to go back to our case. So this is our 18-year-old who developed angina-type symptoms after he had a catheter pulmonary valve replacement. And those catheter pulmonary valve replacements are housed inside a stent as well. So he had a stress echo, which was normal, showed normal wall motion. But given that his symptoms were so concerning for ischemia, and there was a concern that this catheter pulmonary valve may be compressing the coronary artery, he did go on to have a coronary angiography. So these were his images. This was an injection into his left coronary artery here, believe it or not. You can basically see no left coronary artery, and it's right adjacent to where the catheter pulmonary valve stent is located. Here's his injection into the right coronary. You can see a very large right coronary. And you can see collaterals coming right up here into the left coronary artery territory. Given that he appeared to be collateralized and concerned for the potential risk and benefit for revascularization, it was thought to do a test to determine what kind of volume of ischemia did he have to really help decide how to manage him. And at that time, I was at a center where they had ammonia PET scans. Now, ammonia is a really nice radionuclide for nuclear myocardial perfusion scanning with a PET. Because unlike rubidium, which is the most common one, you can only use pharmacologic stress. With ammonia, you can do exercise. It's a very highly sensitive test for diagnosing ischemia, and you can do stress first exercising. So if the stress perfusion is normal, you can avoid the rest stress and decrease your radiation exposure. So with exercise, he exercised for 14 minutes on the Bruce. Stopped, which is not bad. He stopped due to fatigue. He had a normal heart rate and blood pressure response to exercise. He had non-diagnostic STT wave changes, which is very common with our congenital heart disease patients. He did have runs of ventricular bigeminy. With all PET scans, you do get a low radiation, low resolution CT scan for attenuation correction. So you can make sure that there's not extra non-cardiac tissue that's limiting the number of counts we're seeing from the radionucleotide scan. And then with that CT scan, I think in congenital heart disease, you can also get a little bit of anatomic information. So here you can see this patient's catheter pulmonary valve stent here in the pulmonary artery conduit. And this was his nuclear scan. And so for those of us that don't see these every day, we have the short axis going from the apex to the base. Here are in our vertical and horizontal long axis imaging. I think the first thing that pops out to most people is here at the base, we see a big perfusion defect in the septum. So this certainly could look like a septal infarct, except remembering back to this patient's anatomy, he had a VSD and a VSD patch. And so any prosthetic material like a VSD patch will look like an infarct on myocardial perfusion imaging. So this is really likely accounted for by his VSD patch. But for those of you who have really good eyesight or who look at these tests all the time, you might notice another subtle change here. Here in the mid anterior wall, you can see that there's a small perfusion defect. It's there at rest, but is a little bit more pronounced with stress. And so this represented a small fixed defect in the mid anterior wall with mild reversibility. Given that he had just a very small amount of ischemia, the thought was to avoid trying to revascularize this challenging lesion and to treat the ischemia with beta blockers. And he actually did very well. His symptoms improved. So this is our experience with nuclear myocardial perfusion imaging in congenital heart disease, which I put together during my fellowship while I was in Boston. These are the diagnoses of the patients. I only included patients with the more complex types of congenital heart disease. And you can see that the most common diagnosis for having nuclear myocardial perfusion imaging with the transmission of the great arteries with arterial switch. And the majority of these were done as a screening test because of the known risk for coronary events in these patients. But there were, we had a whole myriad of different diagnoses of patients who were undergoing these stress tests. The stress rest myocardial perfusion imaging was abnormal in about 43% of patients. And of those, about 25% had reversible changes, so indicative of ischemia. But when we looked at their coronary angiograms, only 33% of patients with abnormal myocardial perfusion imaging had significant underlying coronary obstruction. So I think, I think these tests in patients with congenital heart disease are not particularly specific, probably because of the difficulty interpreting a lot of prosthetic material. But it can certainly give you an indication whether you need to look further with angiography at the coronary arteries. So in summary, I think we're going to be seeing increasing numbers of adults with congenital heart disease developing ischemia. I would consider ischemia as in the setting of coronary artery disease risk factors or anatomic reasons for ischemia. And there are multiple issues to consider in appropriate diagnostic testing. So considering the physiology of ischemia, the type of congenital heart disease, and ancillary information from the imaging test. And with that, I thank you very much for your attention and happy to entertain any questions.
Hey, Sarah, it's Angie Keeley. Thanks for that great talk. I am wondering about exercise targets as far as time of exercise or heart rate targets in this population, especially the anomalous coronaries. I have had a couple patients over the years who have had initial stress tests where they've exercised to 85% and it's shown nothing. And then if you push them to max effort where they're 90-95%, they go into polymorphic VT or they have bad ischemia. And these are especially, folks who are fit to begin with. So do you have different exercise targets for this population if you're trying to pull out ischemia?
Angie, that's a really fantastic question. I think the first thing that's worth mentioning is, stress testing in those patients with anomalous coronaries. even if the stress testing is normal, there are cases, unfortunately, of sudden cardiac death, even with normal stress testing. That's super rare in our older adults, so adults over the age of 40, but it can happen. And I think your question of heart rate targets is very appropriate. You know, I still tend to, we like to stress our patients to the maximal effort. At minimum, we want to see a target heart rate of 85%, but we certainly don't stop until the patient is at their maximum effort. But I think your point is well taken. Stress testing is not a perfect way to risk stratify our patients with these anomalous coronaries, but it's sort of, you know, at this point, sort of the best that we have. But yeah, but I think to ensure that your patient does exercise to their maximum effort is really important.
David Patton has a raised hand.
Oh, hi, Sarah. I'm over here at Children's today. Sorry, I couldn't make it over. It's good to see your talk. We really enjoyed that here. This is a slightly different question, and it's the patients with congenitally anomalous coronary arteries. For example, like an anomalous aortic origin of the left coronary artery, a high-risk one, intramural or interarterial. We have these debates all the time. Is there an optimal imaging strategy to assess perfusion defects in these anomalous coronaries? We do all sorts of imaging, but I'm wondering, for your perspective, do you have an optimum strategy?
You know, I think that's a great question. I will definitely get some sort of anatomic imaging, generally cardiac CT, although our cardiac MRI, MRIs with coronary specific imaging can often give similar information to the coronary CT. What I tend to do, and this is just my personal bias, and this is in adult populations, I tend to do a nuclear exercise stress if I can, just because that does tend to be the more sensitive test that we have for ischemia. You know, there is a radiation burden, and I know in pediatrics it's a little more challenging just because the stress labs and then the pediatric hospitals aren't as used to doing nuclear stress, and then you're dealing with a longer cumulative burden of radiation exposure. So, I know we actually have debates about this all the time in our pediatric populations. A lot of our patients are undergoing CMR stress, although it's I get a little concerned about that because it's a vasodilator stress, which you don't necessarily it may not bring out ischemia even if it is present, because you're not really augmenting that cardiac output and kind of bringing on that compressive mechanism. So in my adults, I tend to do nuclear stress, but that's just a personal bias, and with the resources we have locally. But it's a great question.
Yes, thank you. I think there was a lot of enthusiasm for bicycle stress within the MR scanner, Dr. Fogel, and so on. But it's kind of interesting to hear that we can't quite get their heart rates up with that. So do you have any further thoughts on like true exercise stress in the scanner?
Yeah, I think that's a great question. I mean, I don't know if we know in you'd probably be able to tell me this better than I can. If those target heart rates are really applicable to pediatric populations. I mean, all this 85% predicted heart rate is really, all in adult populations. So I think that the part of the challenge with the bike and the MRI scanner is that you're recumbent, so it's hard to get the heart rate up a lot, and then you're pedaling outside, just outside the scanner. You have to stop pedaling, get the patient into the scanner, and then start imaging. So that gives you even more time to bring the heart rate down. So I think they are, if the test is positive, then that's really helpful. But if it's negative, I think it's a bit challenging. It's really an issue. I think one way to get around it, no one's generally too excited about doing this, is thinking about like dobutamine stress in the MR scanner. No one wants to have VT in an MRI scanner. But that would be sort of one way to get around it. But I don't know if there's a great way to really ensure that you have a really optimum heart rate to officially rule out ischemia with the bicyclometer.
Okay, thank you for the great answer. That's really helpful when we approach these cases.
Any questions?
Rob has a question.
Great. The question is, do you have any experience with photon counting CT in congenital heart disease with more prosthetic material? So Rob, with that, I imagine that question is in terms of like attenuation correction in our nuclear studies with congenital heart disease.
No, sorry. It was related to like cardiac CT, because there's like these new photon counting CTs, and they're being marketed as a way to get rid of more of the metal artifact if you had significant like surgical material or prosthesis.
Oh, thank you. Sorry, Rob. You know what? I don't have any experience with that. I think that could be really helpful. I have to say we get we have, a lot of stents, sternal wires, coils in the chest. I think, so we can be really limited in some of our congenital heart disease patients with that kind of blooming artifact in CT. I don't personally have any experience with that, but I'd be excited to see if that helps.
Questions in the room here? I have a question about using cardiac CMR perfusion versus perfusion for microvascular disease. You didn't really, I know you kind of just mentioned it, but left it alone. Do you have any kind of interest in microvascular disease?
So we have not. I think it's a really great question, and it's coming up more and more with a lot of our patients with both, with arterial switch procedures. Are there more sensitive ways we can start detecting abnormalities before, coronary events? Actually, just came up at a discussion I had just a few weeks ago. We have not been doing that with MRI. I think it's a great question, partly because, we don't want to have to expose these patients to the radiation exposure from like nuclear assessment. But yeah. Have you been doing?
Yeah, we've been doing quite a lot of cases for microvascular disease, and it seems to work quite well.
I should talk to you about that.
We can talk about that later. If there are no more questions online or in the room, we'll thank Dr. Partington for her wonderful talk. That's fantastic.
Thank you.